Hello, and thank you for joining us tonight for our free webinar, A Contrarian Approach to Treating Low Back Pain, featuring Whitfield Reaves. My name is Jeff Bloom, Education Marketing Manager here at Lhasa OMS. For over 40 years, Lhasa OMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. We recommend viewing the webinar in Chrome, Firefox, or Safari, as you may experience some slowness in other browsers. And to the right of the video screen, you will see 3 tabs: chat, questions, and polls. To chat with other attendees or to communicate any technical difficulties, please use the chat tab. And for questions, please use the questions tab to assure that our guest speaker will answer them at the end of the lecture. Please note that each webinar is recorded, and immediately following the conclusion, you will receive an email with a link to view the video on demand. We will also share the recording with any slides and complementary material in the following week or 2 on our blog. You may always visit our blog and use the free webinar tag to find all of our previously recorded events. From acupuncture to CBD to practice management, you'll find something interesting for every practitioner on the Lhasa OMS blog. Now for our featured speaker, a man who needs very little introduction at this point. It's our 3rd webinar with Whitfield Reaves. Whit has been working in the field of sports medicine since he first began practice in 1981. He earned a Doctor of Oriental Medicine degree in 1983 that included a thesis entitled Acupuncture and the Treatment of Common Running Injuries. Whit's experience in sports medicine includes the 1984 Los Angeles Olympic Games, as well as numerous track and field, ski racing, and cycling events nationally over the last 30 years. He has been in the forefront of the acupuncture sports medicine field, emphasizing the integration of acupuncture with orthopedics and anatomy. He is the author of the Acupuncture Handbook of Sports Injuries and Pain, and his popular acupuncture sports medicine apprenticeship program uses a small group mentorship style setting in the instruction of orthopedic style acupuncture. And you can find upcoming dates on his website, whitfieldreaves.com. Please join me in welcoming Whitfield Reaves.
Hello. Okay, thank you, Jerry. Thank you all for coming out. For some of you, it's late, and the sun is just setting here in California, and let us proceed. So we basically have a title of the triad of the low back, or the triad of low back pain. Many of you probably haven't heard this because I made it up, I think. I don't know of hearing it anywhere else. But essentially, the triad are 3 anatomical structures: the gluteus medius, the quadratus lumborum, and the sacral iliac joint. So inherent in this is the fact that we are speaking of anatomical structures rather than meridian, channel, organ, what have you. So from my 40 years of experience, many of those years struggling with the treatment of back pain and trying to understand back pain, very early on, I saw that bladder 23, bladder 25, bladder 40, bladder 60, a Tai-Yang approach just did not work so well. And it was upon meeting Janet Travell in 1983 and 1984 that I got introduced to some of these structures and how they worked. And for me, that was the turning point. It was not leaving traditional Chinese medicine. It was not leaving Jing-Lo or the channel theory or Zhang Fu or the organs, but it was thinking anatomically and then allowing ourselves to translate into a meridian or an organ approach. After understanding the anatomy, sometimes we would make that translation before understanding the anatomy. But what have you, let us continue. One of the things that I really enjoy is reading Huangdi Neijingling Shu. This was a translation by Mao Xingni in the Los Angeles area. Many of you, of course, know he and his family. And this is a section on the 5 failings. The 3rd failing occurs when the physician lacks deductive reasoning. Much information about the patient's condition is gathered, in addition to careful observation of the body signs and inquiry into the patient's symptoms. After gathering the pieces of information, it is the physician's task to utilize his or her knowledge and analyze through deduction the entire picture of the patient illness. Inability to do this limits the physician's effectiveness. So in this sense, we're talking about analysis. And sometimes we've got big analytic people in our profession, and we've also got very intuitive people who sometimes forget that analysis is important. So I like this. It's something that gives us something to think about. And I would say that the analytics that show up in this lecture is that there is a high statistical probability that back pain, due to any cause, any trauma, any posture, any event, any mishap, that back pain is statistically likely to include the gluteus medius and the gluteus minimus, the quadratus lumborum, and the sacral iliac joint, or at least one of those, or possibly 2 of those. So the triad is using analytics is very, very likely. Whereas, for instance, the paraspinal muscles, where the bladder meridian passes through the inner and the outer bladder meridian, is not a very statistical likely tissue to be driving a case of back pain, even though it certainly looks like it. It isn't necessarily high in the analytics. So we'll talk about that. We'll keep moving with that. But I love this picture. I love how fast we came from Homo sapien walking erect to sitting with flexion, forward shoulder, forward head posture at a computing table and keyboard. And much of what comes out of the analytics of the triad is, in fact, this postural condition situation that presents itself and brings about many of the pain syndromes. So this did not exist in the year 1072 at the time of the bronze statue and the compendium of all the acupuncture points. Hence, we're going to be in each of the 3 structures of the triad, we're going to be needling sort of makeshift zones and points and not pure meridian points like bladder 23, bladder 25, et cetera, et cetera. So we'll start with the gluteus medius. Janet Travell, again, who I was very fortunate to meet. Janet Travell, of course, is who wrote myofascial pain syndrome, the trigger manuals that virtually all of the trigger point, the dry needling, anybody who needles muscles has some lineage and connection with Janet Travell. She calls the gluteus medius the lumbago muscle. Now let's remember the gluteus medius is on the side. It's a gallbladder channel, Shaoyang zone of the body, and she calls this the lumbago muscle. We don't use the word lumbago so much. Lumbago is lumbosacral low back pain, which is Tai Yang. So here's a muscle that is in a Shaoyang region of the body that creates pain in a Tai Yang zone of the body. The gluteus medius is a huge pelvic and lumbosacral stabilizer, so this comes into play in all of the work that we're going to be doing here. So we shall continue. Here's a nice illustration from Janet Travell Barbara Cummings illustrations of the gluteus medius. So here you see we're looking from the side. I do not have a pointer. It's really difficult. So I will try to articulate where you might look. If you go to the greater trochanter and you look between the greater trochanter, the iliac, the arch of the iliac fossa, you'll see the gluteus medius well marked in this illustration. Clearly showing it's on the lateral side of the body. The gluteus medius has X's, trigger points, diamonds, motor points. The belly of the gluteus medius is loaded with wonderful anatomical zones that result in just terrific clinical results for a wide variety of conditions. Here you see on the left side, you see the gluteus medius above the gluteus maximus. And on the right side, you see the gluteus medius cut away, and you see the gluteus minimus underneath. All of it from the vantage point of the iliac fossa. So any needling into the gluteus medius and deeper into the gluteus minimus, we always have a bony iliac fossa that will protect us from hitting organs and hitting other such structures. Here you see the gluteus medius cut away and underneath the gluteus minimus. But these two muscles are just stacked on top of each other, originating in the iliac fossa, iliac crest, and inserting in the region of the greater trochanter. So most of you all know all this. This is what I love. The Trendelenburg gait or posture occurs when on single leg standing, look at the illustration on the right side, on single leg standing, the pelvis drops on the opposite side, the left side, the leg is not weight bearing because of a weak gluteus medius failing to keep the pelvis stable. The left illustration has a strong, activated, intact gluteus medius, and on single leg standing, the pelvis stays stable and relatively level. Now, if you look at on the right illustration, if you look at the results of a weak gluteus medius within the standpoint of structure, look at L3, L4, L5, S1. Those vertebral discs and spaces are really getting beat up along with the facet joints. It's pretty stressful. Look at the sacral iliac joint, just lateral to the S1 and S2 foramen. You can see those little foramens of S1, S2, and you push out lateral and you see the sacral iliac joint tucked into there. And then you can also imagine what this might do to the hip joint by having this unstable pelvis. And remember, when we walk, 60% of the time, we are single leg standing. 30% of the time on the weight-bearing leg of the right side, 30% of the time on the weight-bearing leg of the left side. So we're doing a lot of single leg standing if we're walking around and moving. If we're an athlete and running, or if we're a basketball or a football or a soccer player, you know we're moving through space, and we have periods after the toe off and before the heel strike of the other side where our weight is on one leg. If our gluteus medius is not activated and working properly, then we have this Trendelenburg gait or posture, and we have signs of possible degenerative disc disease or some chronicity or even something acute. Eventually, muscles tighten up because they don't like all this cattywampus pelvis. They want to tighten things down, hold it together, and we've got low back pain, all because of a weak gluteus medius. Here you see on the lower picture there a woman running. She's weight-bearing on the left leg. Look at that right hip dropping down. That is a Trendelenburg gait. That is not good. Her lumbar spine is stressed. Her sacral iliac joint is stressed. Her hip may be stressed. and all of the structures of the lower extremity, the patellofemoral joint, all the way down to the Achilles and the plantar fascia. Everything could be compensating because of this. So I hate to pick on her because she just might be on a slanted trail, and she might have perfect posture, pelvic posture. So the triad is the gluteus medius, but we have to include the gluteus minimus. Janet Travell calls the gluteus minimus the pseudosciatica muscle. So this muscle produces pain like the gluteus medius, which produces pain in a lumbosacral, lumbago sort of referral pattern. The gluteus minimus is the pseudosciatica muscle, and it sends some pain down the leg. And it can go down the lateral iliotibial band side, the L5 side. It can go the gallbladder channel. It can go down the posterior thigh, the S1 zone, or the bladder channel. So sometimes sciatica is a referral pattern from the gluteus medius and not from compression of the sciatic nerve or a nerve root impingement. Kind of important to be able to figure that out. Here we see the gluteus medius cut away. We see the gluteus minimus deep to that. Here we see the gluteus minimus with trigger points and a motor point with that diamond. But if you will remember the gluteus medius illustration on top with all those X's, and then you have all these X's of trigger points of the gluteus minimus, you have a whole iliac fossa, a whole lateral Shaoyang gluteal zone, all of which that can have usher. And you all have all seen it. You've all done it. You've all needled into usher points. And what I'm going to suggest, that we use the extraordinary point Jianhua. You can find this in the Shanghai text. I reference this by understanding that the point Jianhua was always point sensitive, and that point was halfway from the greater trochanter to the iliac crest on the Shaoyang side, straight up that iliotibial band. Not gallbladder 29, which was more anterior. And I looked through the Shanghai text, found the name of this point. I have never had a teacher present Jianhua as an acupuncture point. By the way, Jianhua means strengthened thigh. So as we get through this, that might make more sense to you. Let me just back up to the slide we passed. I've talked about the referral patterns of the gluteus medius and minimus from the work of Janet Travell. All those red dots and shaded areas are potential zones of pain referred by both the gluteus medius and the gluteus minimus. So on the right side, you see that tibial band, that L5 zone. On the second to the right, you see it going down the bladder channel, the S1 zone. And when you look at all this kind of mush together, there's a lot of possibility of Taiyang back pain as well as leg pain, totally referred from the gluteus medius and or the gluteus minimus. We have to know this. We have to be prepared for this. So in treating the gluteus medius, I'm going to suggest at this early stage, rather than chasing down Usher points, let's go to a point that every one of you has gone to before without necessarily knowing that this was, a known entity. The extraordinary point Jianhua, follow the words here. Halfway between the greater trochanter and the iliac crest on the Shaoyang line, posterior to the ridge of the tensor fascia lata, the TFL, in a palpable depression, and use Usher to confirm. The patient can be lateral recumbent, or the patient can be prone face down to be able to find this. If we go back a little bit, we can go here. You can see that Jianhua you can imagine by figuring out where that greater trochanter is inferior, it's halfway from the greater trochanter to the iliac crest, and it's right posterior to that taut, banded tensor fasciolata that you see illustrated here with gallbladder 29 as a point in or in front of. We palpate perpendicularly for the extraordinary point Jianhua, always looking for a depression. We needle perpendicularly, exactly in the same vector that we palpate. We use a 75 millimeter needle in most patients. I use a 0.25 by 75. I use either a MAC or one of the wonderful needles that Lhasa distributes with Sarin. They have wonderful 0.25 by 75 millimeter needles. I usually use two paired points, two needles together into that zone. And I use this language called point density of how dense does that tissue feel. And generally speaking, the needle will pass through the medius with a lot of ease. There's not a lot of resistance until we get deeper to the gluteus minimus, which is more dense, and feel the needle get into the denser muscle. And that's often when the patient will go, oh, I feel the chi. Or the patient may even say, oh, I felt that kind of go down the leg a little bit. Remember, the gluteus minimus, the deep muscle, has that referral pattern down the leg. Back to the beginning of this, we're doing two things. We'll start with the second. We're treating fibrosis or trigger points. That's a possibility. And actually, I want to stay away from that in this lecture. What we're really doing is we are activating or disinhibiting an inhibited muscle. So we've talked about the importance of the gluteus medius being activated to maintain pelvic stability. For whatever reason, prolonged sitting, driving in cars are two huge culprits. Perhaps sitting at a desk with forward flexion may affect the L5, S1 nerve roots, of which the gluteus medius has innervation from L5, S1. Something happens to this muscle and it gets inhibited very easily. It would behoove you to learn how to manually muscle test the gluteus medius, which is an abductor. It lifts the leg up to the side. And so if you do manual muscle testing, you'll find that often that muscle is weak. Go onto YouTube and learn how to test manual muscle test the gluteus medius. It will help you very much understand that this muscle is not working, and it will also help you understand that needling into Jianhua will turn that muscle on quickly. So we are activating an inhibited muscle because the gluteus medius is a phasic muscle. Phasic muscles are muscles that are available for immediate activity and movement, to go hunt, go bring home dinner, what have you. Very, very primitive DNA, in these muscles, make them available on demand. But if anything is wrong, prolonged sitting and driving cars, clutching, any of a number of things, falls, cyclist falling on his or her side. If anything goes wrong, this muscle inhibits. It just turns off because the body thinks that's the best way to prevent prolonged injury. So the muscle inhibits and we need to activate it. Now, the second aspect of this is treating taut bands in fibrotic portions of the muscle. We're going to leave that alone now. We have a gluteus medius tendon that can get very fibrotic and trigger point, what have you. Let's just talk about activating the gluteus medius. It may be the single best thing that you've ever learned from me and from this lecture, if you don't already know this. So, number two, the triad, the Quadratus lumborum. Now, the set structure of the of the triad, the quadratus lumborum, is a lumbar region muscle that Janet Travell calls the joker of low back pain. The Joker movie just came out. We all know the essence of the Joker. Very stealth, very hard to find. You're not sure where. You think it's here, you think it's there. Well, the quadratus lumborum is the joker of low back pain, with wild referral patterns throughout the Tai-Yang as well as Xiao-Yang distribution areas of the body. So you can have pain both on the muscle as well as referral patterns to adjacent structures. Okay, so, and when we look at the quadratus lumborum, you'll see that it attaches to the 12th rib in the transverse process of L1, L2, L3, L4, and oops, that little red attachment to L5 transverse process is the iliolumbar ligament. Theoretically, that should be gray or just not muscle colored. But you can see that this muscle tends to have a going out feel to it rather than up and down. Remember that the paraspinal muscles, where the bladder meridian is embedded, are extensors, erectors of the paraspinal muscles. This is deep. The paraspinal muscles sit on this quadratus lumborum, and this muscle is deep to them, to the paraspinal muscles, and it goes out lateral. And so hence, when this muscle tightens and contracts, it'll hike the pelvis up on one side. Paraspinal muscles cannot do that. They don't have that kind of strength. Let's look at this a little bit more. Here you see the quadratus lumborum on the right side. And if you look carefully, you'll see that the paraspinal muscles have gotten cut away. And so you see the vertebrae. But you can see the quadratus lumborum is deep to the paraspinal muscles. On the left side, you even have the wraparound core muscles of the oblique interior, oblique exterior, and the important transversus abdominis muscles as they wrap around and have fascia that connect to the paraspinal muscles. So here you see the deeper nature of the quadratus lumborum. You have this hint that the muscle is going out a little bit, so it's not parallel, it's going out a little bit. It has a little bit of a Xiao-Yang feel to it. It's not just straight up and down like a Tai-Yang channel would be. Here's a nice illustration, and when I see this illustration, the quadratus lumborum, I understand this is not a phasic muscle. This is a postural muscle. And that is really good engineering. It's like post and beam construction. If you're going to build a house, this is kind of how you want it to look, really, really well stabilized. But the quadratus lumborum, as a postural muscle, shortens and tightens. So we're now in a whole different world from the gluteus medius, which needs activation because it inhibits. Now we have a muscle that shortens and tightens and creates havoc and tension. We have a muscle that we just need to release and elongate. So here you see along that lateral edge of the quadratus lumborum, again, this is deep to the spinal muscles. You see a trigger point right below the 12th rib. You see a trigger point right above the attachment on the iliac crest. And then you see a motor point level with about, L2. Now, when you look at the descriptions, let me see if I've got something that helps here. If you look at the descriptions of both P-gun and Yao-Yan, the two extraordinary points, they're greater than 3 lateral to the posterior midline. So the fact that they are greater than 3 tsuen lateral means they're no longer on the paraspinal muscle. So you go around the corner, you roll off the paraspinal muscles, and here you have this ridge or this edge of the quadratus lumborum. And this is the access point. And the access to the quadratus lumborum is from the Xiao-Yang side. We come in from the side, and we palpate this ridge like this. And we are palpating towards the vertebral body, but deep to the paraspinal muscles. So if you go around, roll off the paraspinal muscles, you get further lateral than 3-2, and then start palpating towards the vertebral body, you will find these points that will almost never be revealed with perpendicular palpation. So, treating the quadratus lumborum now is about releasing a shortened, tightened postural muscle. I've already said that. We use the extraordinary points from P-gun to Yao-yan, anterior to the paraspinal muscles, in the palpable ridge or edge of the quadratus lumborum when palpating from the side, transversely in the direction toward the vertebral body, using Assure to confirm, and the patient can be lateral recumbent or prone, and needle anywhere from a 50 to a 75 millimeter needle, depending on the size of the body. But you need some distance to be able to get under the paraspinal muscles to the quadratus lumborum. And of course, you also have to use caution. The wonderful thing about the gluteus medius and minimus is we have an iliac fossa, bony, nothing is in the way. In the case of the quadratus lumborum, we got kidneys and we've got internal organs that we have to be more careful with. So again, there's our quadratus lumborum that we access coming in from the side. Should be very simple. Some of you do not know this muscle. You need to get someone to teach you. Those of you who do know the muscle know how wonderful it is when you can find Assure. When, for me, I spent 3 or 4 years of perpendicular palpation into bladder 23, bladder 25, never really feeling like I had the right point. And once I learned to come in from the side and go to a different structure, everything changed. The quadratus lumborum changed the way I thought and think about the way the back works and the causes of back pain. So we're going to leave that alone. The third structure of the triad is the sacral iliac joint. And by the way, I'm going to show you some video of needling each of these. So you're going to get some visuals. If you have time, I can run them through twice. The triad, the sacral iliac joint. It's an often overlooked cause of pain and dysfunction by the practitioner of traditional Chinese medicine. I have never seen the SI joint written in a treatment protocol for back pain or differentiating the sacral iliac from some other, from soft tissue or what have you. So I don't know. I don't read Chinese, so maybe I've missed the good stuff, but everything that has been translated that I've seen leaves out the sacral iliac joint. It is important. You need to use it. Pain at the site of the joint, pain and Assure confirms the possible involvement of the SI joint. So important is this, that I have given up all of the orthopedic testing involved in trying to assess a sacral iliac joint dysfunction. And all I do is palpate for Assure. If it's painful upon palpation, the SI joint is a synovial joint. Synovial joints are capsules. They're communities like an old wall city in Europe. You know, if everybody is happy, you palpate, you knock on the wall, knock on the door, someone will answer, you know, maybe they'll keep you out, but everything is fine. When you palpate the access to a synovial joint and it's painful, whether that be gallbladder 40 and the ankle joint, the talar joint, whether that be the acromioclavicular joint or the shoulder joint here, if it's painful on palpating up against the synovial access zone of a synovial joint, then you're pretty sure there's a problem with that joint. And there are studies that have actually suggested that what I'm saying is correct, that statistically you have just as likely of a chance of making a correct diagnosis solely by palpating Assure over the SI joint. If that's the case, let's make sure we get to the SI joint correctly. So my pointer or lack of pointer makes it really difficult here. But if you look at this posterior sacrum and ilium, you can see on the right side, for instance, the protruding PSIS, the posterior superior iliac spine. And if you go medial and inferior, you're going to get into the zone of the sacral iliac joint. But remember, we've got two things. We've got ligaments that have strapped this joint together to hold it together. And then deep to it, we have the synovial joint itself. So we got two pieces here. We've got ligamentous structure and we've got articular structure. Two different types of anatomical structure, but if we needle deep, we can penetrate through both. Now, back to the Trendelenburg gait, you can see here on the right side, if the gluteus medius is weak, you can see that hip is hiked on that right side. You can imagine that the quadratus lumborum, which attaches superiorly, shortened and tightened and pulling the hip up. But you can see how the sacral iliac joint gets really extra wear and tear, let's say, and extra stress on the joint from this type of posture or gait or this condition. So the interaction between the gluteus medius, the quadratus lumborum, and the SI joint fits in there. And so you can see from the foramen at S1 and the foramen at S2, you go lateral, and that goes toward the sacral iliac joint. Here you see also from this first and second posterior sacral foramen, you go lateral, and you can see how you can slip into the sacral iliac joint. This is my favorite. You got S1 and S2 posterior sacral foramen. That's bladder 31 and bladder 32. You go a little further lateral, technically 1.5 lateral to the posterior midline. You get to bladder 27 and bladder 28. And then you go a little bit further lateral and you slide into the opening of the sacral iliac. It is a zone between S1 and S2. By the time you get to S3, you can see if you go lateral, you're going to hit the piriformis. Here you get a good visual of how you need to slide along the sacrum and go deep to the lip of the ilium at the PSIS. And hence, what we do is we find this location and then we palpate 45-degree oblique lateral. We palpate 45-degree oblique lateral. That will confirm with Usher if the SI joint is involved, and then we needle 45-degree oblique lateral. That is the direction our needle will travel as it slides along the surface of the sacrum, but deep to the ilium. Again, we'll see this here in a minute. Now, of course, doing that, we are penetrating ligaments. And I always say ligaments love needles and ligaments love electrical stimulation. They carry the current, they invigorate the needle, mechanical needling and electrical stimulation invigorates ligaments wonderfully. And if you have a lax ligament, and remember the posterior sacral iliac ligaments get loose with women during childbirth. And because we always give women a chance to get back to a healthy state before they start working, or the woman is sitting, prolonged sitting too early, too soon, these ligaments don't get their same integrity back. And we have a sloppy, loose joint with ligamentous laxity. The needles with E-stim do wonders for those ligaments, as well as deeper into the joint for inflammation, pain, and invigorating chi and blood into the joint. So treating the sacral iliac joint We're treating laxity in the ligament destruction over the SI joint, and we're treating the synovial joint capsule deep. The SI joint zone is lateral to bladder 27, bladder 28, lateral to the first and second posterior sacral foramen, as we've said, and coming from the other direction, it's posterior and inferior. No, I guess we would better say that it's medial and inferior to the posterior superior iliac spine. In the palpable depression, when palpating 45-degree oblique lateral, use Usher to confirm. Position lateral recumbent or prone. 50 millimeter to 75 millimeter needle is most common, a 2 to 3 inch needle. So those are the three structures of the triad. I would contend, actually, let me go to number 5 on this list of features and benefits of the triad. Let me just go to number 5. These three anatomical structures, when needled properly, are extremely effective and are involved statistically likely in most cases of low back and hip pain. So whatever the cause, whatever else might be happening, bulge discs, set joint syndrome, annular ligament tear, loss of disc height, I don't care. You know, trochanteric bursitis, iliopsoas, all the diagnoses roll on. But what is always in common is 90% of the time, the gluteus medius and minimus, the quadratus lumborum, and the sacral iliac joint are all involved. And so the acute back patient can come into your office and you can be confused as to the causes. You can be unsure, but if you have palpation of Usher at Jin Qua in the muscle belly of the gluteus medius, and manual muscle testing shows that it's weak or inhibited, you need to use it. If palpating somewhere between P-gun and Yao-yan on that lateral edge of the quadratus lumborum produces clear pain, the patient goes, that is it. Sure. You've got to use it. And if palpating 45-degree oblique lateral into this SI joint space, the opening of the synovial joint produces Usher, you've got to use those three structures. And you may be able to get through. I don't care if they are saying, I've got pain from bladder 23 down to bladder 26 and what have you, even further up the spine. I don't care where they say they have pain. They don't know where the pain comes from. They don't know where the pain is being generated. And these three structures generate a lot of pain. And the pain is often not where the structure is located. So let's go back up to the top. The gluteus medius and the gluteus minimus are easy to access and they have no major nerves or vessels to contend with. So this is easy. You palpate it. You've palpated this many times and found the extraordinary Jin Qua. Very simple. This uses a very pronounced Xiao-yang approach rather than Tai-yang. So both the quadratus lumborum and the gluteus medius are much more Xiao-yang in nature. So we're going down to gallbladder 34, gallbladder 41, much more likely than going to bladder 40 and bladder 60. The quadratus lumborum, while more complicated, remember it's the joker of low back pain, while more complicated in terms of location and needling, responds well to manual therapy and cupping if acupuncture is unsuccessful. Acupuncture is not unsuccessful usually, but if sometimes you can't get to the muscle correctly, you're just not sure how to get there, or you're a little being so cautious that you're not quite making this work right. So the quadratus lumborum has other ways, and manual therapy is wonderful and easy. And the sacral iliac joint is often underdiagnosed in medicine. So we've got lots of reasons to like what we're doing here. And then in summary, we've got the three structures. You see this needle sizes. We're going to be using distal points on the Xiaoyang, but we need some Taiyang distal points perhaps. Of course, the sacroiliac joint being very close to bladder 27 and 28. Of course, that's a Taiyang zone. So we have to give Taiyang a little bit of credit where credit is due, but Xiaoyang drives this condition from a soft tissue point of view. So I want to leave that there, and maybe we can get Jeffrey here, and we'll look at some video. But why don't I just see, Jeffrey, if there's any question? I've been talking fast and furious, and let me have a sip of water and see if any questions that we can take a few questions now before we go to the visuals.
All right, so we do have some good questions here, so let me get started. Let me know when you're ready.
Fire away.
All right, so Star would like to know, needling into the glute, are you worried about hitting the sciatic nerve? I understand that many people's sciatic nerves can be shaped differently.
The gluteus medius, can I still use a PowerPoint here?
Of course.
The gluteus medius, you can see on the right side, it's labeled there, and that's two states over, that's from New Jersey to Maryland difference, to where the sciatic nerve is compared to the muscle, the gluteus medius. So there should be absolutely no problem with the sciatic nerve. So.
All right, we have another question. This one's from David. How to make sure to avoid kidneys when needling QL trigger points? And thank you.
Well, that's a good question. I would venture to guess that as a profession, we've needled some kidneys. We, meaning all of our profession, have needled kidneys going to the quadratus, into the quadratus lumborum. If your patient is lateral recumbent and you are very careful in palpating the band, the muscle belly of the side, that edge of the quadratus lumborum, and your needle is directed towards the vertebral body, you should be very safe. And that being said, you need some help and you need some experience. You could have the patient face down, and here then maybe gravity could drop the organs down a little bit, and then you're going to needle, now you're needling parallel to the treatment table towards the vertebral body, and perhaps the organs are a little bit more out of the way. If your angle is toward the vertebral body, you should be safe. And if you have any hesitation or any question, then use manual therapy. Manual therapy works very well, and even a cup along that 3.5 Fortune lateral zone off the paraspinal muscles can suffice. So takes experience. Someone's going to have to help you if you're not sure. It's a good question. I think I worry about it all the time. But I've been teaching this for 20 years in my apprenticeship programs, and we don't seem to have ever had a problem. And we seem to get through this okay. So I am willing to teach it and supervise acupuncture students in the treatment of the quadratus lumborum, which I would not do if I didn't think we could do it safely. So,
all right. I think the next question might have been very similar. So can we go over needling of QL to avoid the kidney? Is it lateral to medial needling?
We'll do the visuals, and if that question doesn't get answered, you can answer again after we put on the video. Yeah.
Perfect. Do you want to do another question?
Yeah, sure.
All right. Looks like Emily would like to know, I had another orthopedic teacher caution needling pigeon, P-I-G-E-N, because the lungs can come down past the 12th rib. Any thoughts?
Yeah, so yeah, you can definitely have a kidney, inferior pull of the kidney, and an inferior pull of the lung below that 12th rib. So if you are needling towards the vertebral body, you will not hit the lung and you will not hit the kidney.
All right. Nancy Grossman asked, needling the SI joint 45 degrees oblique lateral, do you mean needling towards the hip or the spine?
I mean needling towards the, away from the center line of the spine toward the hip. So if you look at the illustration we have up there, I've got a better one here. If you look here, 45-degree oblique lateral, you're needling lateral to S1 or S2, and you're going toward the hip or toward the ilium. So you're trying to get the needle under the lip of the ilium into that joint, into that hinge joint that you can kind of see theoretically that exists in there. So no, 45-degree oblique lateral is going away from the center line.
And then Karen would like to know, in a person with scoliosis, any suggestions for finding borders of QL as it seems so much shorter, I guess from being constricted all the time?
Constricted, contracted. I love treating scoliosis with the triad. Treating scoliosis with the triad is brilliant. And doing it on the letting usher get you to the side that is handling all of the stress of the scoliosis, and never chasing up the lumbar and the thoracic spine. I never chase. What is a needle going to do in those muscles up there? I mean, it just seems, I tried it, of course, and many times. All of my treatment of scoliosis is focused on treating the three structures of the triad. One-sided on the side that is handling the biggest brunt of the postural support, all found by palpation. Yeah.
All right, and then Ryan would like to know, does pregnancy, childbirth affect needling, the use of needling?
I just don't needle anyone that's pregnant, and but postpartum is huge because the ligamentous structure of the sacral iliac joint, that ligamentous structure, all these posterior sacral iliac ligaments stretch. The pelvis has to open up. They don't, often we don't drink dangwai and chicken soup. We don't do the things we need to do to get all the chi and blood back into the ligaments and back into the joint, and it doesn't seat properly. And so many postpartum women have huge SI joint problems, although you can also have a sacral iliac joint problem from trauma, from falling on the side, a cyclist that falls on their hip on the side, or a soccer player that lands on their side. That can create jar the sacral iliac joint and have a type of sacral iliac itis, perhaps. But yeah, so pregnant, I just don't do. Postpartum, I'm always looking for the sacral iliac joint, try to rehab that and get that back into a ligamentous integrity that it needs for to be healthy and have posture and no pain. Yeah. Why don't we follow question? Why don't we take a look at some pictures?
Okay.
And then we'll get back to questions. I'm happy to answer more questions. So let me see. Now, if I can remember how to do this, I'm gonna I'll remember how to do this.
Do you want me to do it?
Yeah, why don't you put up number one?
Okay. So I'm gonna mute both of us. So give me like a thumbs up when you want your voice back.
Okay.
All right. So we're gonna do the first video here.
Okay, so we have the iliac crest. We have the greater trochanter, which we'll just mark up like this. halfway between the two is the region of the muscle belly of the gluteus medius. We have the fibers of the tensor fasciolata, and we just want to roll off the fiber, the tensor fasciolata, right into this zone that was already marked because it's highly predictive. This is the point Jian Qua, halfway from here to here, posterior side of the TFL. And we'll use a perpendicular needle insertion with a 25 by 75 needle, and we'll just go straight into the iliac fossa, and we'll be stopped at some point by bone, and we're stopped by bone. So she doesn't have a deeply sculpted iliac fossa. We'll go a little bit more posterior and see if we can get a needle deep through the medius and through the minimus, increase density in the minimus right here, and we hit the bone there. So in this particular case, this is a 3-inch needle, and we're only about 1.5 inches, only halfway through there. Some patients, this will go all the way through. But this is Jian Qua and posterior Jian Qua, and that's it.
Okay. All right.
Number two.
Number two, ready? All right.
Number two.
Okay.
All right, the sacral iliac joint, if we follow the iliac crest around to the posterior superior iliac spine and go medial and inferior to the posterior superior iliac spine, we could find this region of the sacral iliac joint. We want it to palpate as point sensitive. Here's the top of the sacrum, and this would serve you very well to palpate top of the sacrum to make sure that you're getting all the way down on level with S1, S2. The needling of the sacral iliac joint is oblique, 45-degree oblique lateral. So here is the needle, oblique lateral. Here is perpendicular. Here is oblique lateral. I have no idea if this will make it in, but we shall see. We will take a 75 millimeter needle, and we'll let it continue 45-degree oblique lateral. And we have a female, pretty small pelvis here, and we have got a 3-inch needle that just slides right in. Wow. When you're 45-degree oblique lateral, you almost always are assured of sliding along the sacrum, but deep to the lip of the ilium to get into there. So this is a good needle. I wasn't sure we could do that. All right. So remember the SI joint, 45-degree oblique lateral. If it doesn't work this way, the patient goes prone, and then you palpate 45-degree oblique lateral.
We're ready for 3? Okay. And video 3.
The Quadratus lumborum. There's the iliac crest. Here is the 12th rib. We go 3 Tsun lateral. We get the paraspinal muscles. You can clearly see the paraspinal muscles here. We know deep to the paraspinal muscles is the QL, and we palpate oblique or transverse in a way, cross fiber of the paraspinal muscles, but deep to the paraspinal muscles, we palpate toward the vertebral body, and we're up against the Quadratus lumborum, deep to the paraspinal muscles. Here we have P gun right below the 12th rib.
Here we have the region of the motor point about L2. This is level with L1, level with L2. And then Yao Yan is above the iliac crest. The Yao Yan that we use is above the iliac crest in the attaching fiber, the QL. Clearly the most important two zones are the upper attachments. And here I'll use a 50 millimeter, a 20 by 50. If I had a larger patient, I would use a 75. It's possible if I had a smaller patient, I might use a 40 millimeter needle. In this case, a 50 by 20. So we've got a needle that we're going to insert perpendicular to the table, perpendicular, directed toward the vertebral body, and we're going to be deep on the anterior side of the paraspinal muscle. So you can see here that we're in front of, anterior to the bladder channel, going along muscles and just needling toward the table. Now the patient always, we want them lined up like this so that we can just get a needle perpendicular. The patient's flopping one way or the other. All of these wonderful, simple angles don't hold up. Okay, and I should right here feel increased density as we push up against the fascia of the quadratus lumborum. That's about halfway on this 2-inch needle. And if we push through it, we push through it, and our patient made a little noise. So again, a 2-inch needle, needling toward the vertebral body on the anterior side of the paraspinal muscles, past the 3-inch line, past the outer bladder meridian. And here we come up against the density right there, and we push through that fascia. And now we're in the QL right here, and it's denser, it's more squeaky, and often one of these two needles will initiate a fasciculation. Both of those needles now are almost fully inserted, so we're 1 3/4 inches deep. We're in front of the paraspinal muscles into the quadratus lumborum. This is the triad: the quadratus lumborum, the gluteus medius, and the sacral iliac joint. Learn to love the triad: the quadratus lumborum, the gluteus medius, the sacral iliac joint.
All right. Do we want to show any other videos, Whit? Or do you want to replay anything?
No, that's good. Why don't you put the slides back up, and I'll say a few things and I'll answer some questions. One of the things is you'll see that in several of those cases, I had 2 needles into the tissue. I had 2 needles into the gluteus medius. I had 2 needles into the quadratus lumborum. I will often use electrical stimulation into those points. It's a very big part of this. I usually have 2 needles in the sacral iliac joint, of where I really like E-stim, because the current seems to really work well with ligamentous structure. So electric current, I think, is E-stim is a very, very useful tool in this treatment. It doesn't aggravate much like it can in other types of situations. And you can follow this with cups, like, for instance, a sliding cup along that edge of the quadratus lumborum could be done after the needles are taken out. You could even put a cup over the sacral iliac joint. On the gluteus medius, after removal of needles, you could do a sliding cup or a gua sha tool to try to work that muscle. So you could include manual therapy, cups, gua sha. You could even theoretically, for instance, on a cold B syndrome of the sacral iliac joint, moxa and drive moxa onto the needle top, needle top moxa into the sacroiliac joint. So you can use a number of other techniques around this, but electrical stimulation is, I think, really fairly important in this kind of anatomical musculoskeletal environment, that we're working. And of course, I'm going to be doing some distal points. I like gallbladder 34. I like gallbladder 41. I like bladder 60. There's a number of distal points that can work very, very well with in treating the triad. So all things to think about. I think that it's important to understand that these three structures can be significantly involved in injury, but they also can be significantly involved just in compensating for problems. The inhibited gluteus medius creates all these problems where everything is trying to balance itself and overcompensate and what have you. So you've got lots of ways to view this, but in treating low back and hip pain, these three structures stand out often. Now, you need to do other things down the road, but I am totally willing to start my treatment with these three structures and have nothing needled on the paraspinal muscles of the low back, for instance, initially speaking. So, but yeah, let's keep going with questions. I could talk for a long time about this, but I probably should listen. So,
so we do have actually a bunch more questions coming in. The next one was from Francesco. I think he's just trying to confirm something that you talked about earlier. So he said, palpate 1.5 soon lateral to bladder 27 and bladder 28, needle at a 45-degree angle toward lateral, and I am in the SI joint area. Did I get that right?
No. Bladder 27 and bladder 20 are 1.5 Sun lateral to the posterior midline. That's the bladder channel. We know it's 1.5 Sun lateral to the posterior midline. You want to go a little bit further lateral, maybe about 2 Sun lateral, to get to that zone where then you would place a needle that would be a weak lateral. So I think what I understood you saying is, do you go 1.5 Sun further from bladder 27, 28? That's too far. You'll be on the ilium at that point. So maybe a half a Sun to, it's a half a Sun to 1 Sun lateral to bladder 27, 28, but we don't know where is bladder 27, 28. Those are hard because it's right on the sacrum. It's bony. There's not a target like there is, like bladder 23 is right in that soft depression of the paraspinal muscle. That's an easier point to understand. Bladder 27 and 28 are, to me, more theoretic. They're measurements. So I would think 1.5 to 2 Sun lateral to the posterior midline is your starting point for inserting a needle into the sacral iliac joint.
Perfect. Ben would like to know, what frequency would you recommend for ligaments like the SI joint?
Oh, good question. I started off by analysis. I can say that at this particular point, I do not like what anybody thinks they say or thinks they know about electrical stimulation. I don't think anybody that I've met, I don't think anything that I've read has convinced me that they know or their study is clear enough to absolutely dictate this is the frequency, this is the hertz, the et cetera, et cetera. So I think that however you've been taught to do E-stim, do E-stim. I don't think it matters. I think it's current that's introduced into the tissue and the body likes current. Now, what do? I use an E-stim 2 machine that I bought from Lhasa OMS that I love. You can kick them, you can sit on them, you can throw them against the wall. You can take them out to a race and have a car run over them and they still work.
You do that.
A Pantheon, you look at a Pantheon a little weird and it breaks, you know, and it's an expensive machine. So I keep the Pantheon in the office, but to get around the eStim2 machine, I like a lot. I use my millicurrent, not microcurrent. Many people are hip cool on microcurrent. I'm not hip and cool. I'm old. I'm almost 70. I'm a milliamp kind of guy, right? I use a continuous sine wave of about 6 to 12 hertz, somewhere through there. Not all your machines can do that. A Pantheon can give you exactly 10 hertz. The eStim2 machine is a little sloppy on the dial. So I really just like, you know, follow the bouncing ball or, you know, whatever. I just look at the flashing light and I want it to be flashing at about, you know, 6 to 12 hertz or flashes per minute. So, so it's a continuous wave of milliamperage, not microcurrent. And I turn it up just to patient comfort. You know, I like it to be tapping. I don't want it to be contracting and painful and agitating. Just a nice little tapping as it fasciculates a little band of muscle or what have you. So very, very simple. Am I right? Probably not. Will there be, does it work for me? Absolutely. Will there be evidence at some point exactly what frequencies are good for what kinds of things? Yes. I don't think any of that information now exists. All of the information on opiate receptors, I'm not treating an opiate receptor. I don't know if you are, and I don't know if you were, if you knew how you would be making a treatment to an opiate receptor. I'm needling muscle bellies. I'm needling fibrotic bands of muscle. I don't know about opiate receptors. That's not the mechanism that I'm working with. So any of the studies that may or may not be correct about opiate receptors is of no interest to me at this point. At some point, I could just say, okay, you've got the right way, I'll change. But for 40 years, this is where I've ended up, and I'm moving until I see evidence otherwise. I'm stubborn, I guess.
Well, I will say that if you do throw your eStim2 against the wall, it will void the warranty, so I don't recommend doing it.
Okay. Yes, sir.
Next question is going to be from Star. I've heard Whit say to never needle tendons. Is this rumor true?
Never needle tendons. We've got tendons all the time, you know? So I needle tendons all the time. So no, the rumor is not true. Do I put a needle through an Achilles tendon to treat encephalitis that was done 1,000 years ago to save a child's life who had encephalitis and this thing worked? I think that's a pretty good treatment. In the year 2020, is that what we're doing with childhood encephalitis? I don't think so. I don't think we do that. If you have an elite athlete and they're worth millions of dollars and their agent and their orthopedic doctor standing there, are you going to jam a needle through the Achilles tendon and be able to justify the
Okay. Let's see. What, are you frozen?
I don't know.
Oh, nope, we're good. Sorry.
So are we good?
Yep.
Okay. So I don't needle, I do not needle into a tendinous tissue. I think that there's no evidence to suggest that this is good for the tendon, although maybe there are some cases where it could be. So, so no. So I go around tendons and I tap on tendons and I like to slide along tendinous sheaths, but penetrating into a big tendon with a fat needle is not what.
And then Bill.
The rumor is true and not true.
All right. Bill has a question. There is a branch of the iliolumbar ligament that goes anteriorly to the sacrum. Is there a needling technique for accessing this region?
I don't have an. There is, and there are practitioners who teach that. I don't teach that, and I don't use it so much. So it's not something I can intelligently talk about. I don't have any good illustrations where I could kind of make my point. So I'll pass on that one. But yes, it could be done. Yes.
Patricia says, my patient had an adverse reaction to cupping in the low back and needles in hamstring and low back after treatment, and she wanted to see if you had any suggestions on how she could prevent this in the future.
Sounds like a fairly unusual patient. Adverse reaction to cup and needle.
Yes.
Yeah. I would need to know much more. If you want to write me a little bit more details of what the reaction is and what you were doing and what part of the body, what part of the skin was. Write that to me. I don't have enough information to answer it. So. And I might not have an answer even with information, but feel free to write me. You've got my website there, and you can just hit contact me from my website. Be happy to help. And also, I'm not trying to sell, but I'm selling. Lhasa OMS has a lot of my webinars, and we have a number of webinars that are coming in the future that we've been really busy on recording and getting some high density needling video. The video that you just saw was we just set the darn thing up and shot. That was in a classroom setting, but in a clinic, in a controlled setting, we're going to have much better visuals. So what we have now is great. It's old. It's more than 10 years old. It was before high definition video. The new stuff is all HD, so it'll be useful. I hope. I've worked hard at it, so that's coming along. Watch Lhasa OMS for it. So I'm done selling. Go ahead.
I just put a link in the chat to the online CEUs that we're currently selling. So we have the full series. You can also purchase them by course as well. I also put a link with his calendar so you can see where he's going to be. There's also a new apprenticeship program that's going to be starting up in Boulder in March, if I'm correct, taught by some of Whit's top assistants. So very exciting. So check out that link that I provided so you can see more information on that. We do have some more questions. If you're hanging there.
Yeah, and just as a note about the apprenticeship program that's going to be in Boulder, understand as I approach 70, I got to pass this information on to my wonderful colleagues that have assisted me for years, for a decade or so, and so this will be the first time that the three of them teach this material without me there. And they will do a wonderful job. And this will be in Boulder, Colorado, where my wife was the director of Southwest Acupuncture College, and she hired me, and I taught there, in the classroom. But my first apprenticeship programs were all in Boulder, Colorado. And so that's going to be coming up. You can see that on my website and elsewhere on Lhasa's website. You want to get this material and you don't want to come all the way to California to do it, and most of my programs are pretty full right now, this is a chance, and this is a first opportunity to have some fresh young people instead of my same old stories that I've been telling for 25 or 30 years. So it might be a fresh start for some of you. Yeah. So at any rate, question. Yeah.
Let's see. Next question is from Yvonne. How would you use cupping for the QL to be able to affect that deep muscle?
I would get a cup in the zone where we needled, about 3.5 cun lateral to the posterior midline. Maybe the cup is halfway on the paraspinal, halfway off. We're up against the edge of the QL. It's not a home run. That cup is not a perfect treatment. It doesn't get all of the muscle. And remember, it's a postural muscle that is contracted and shortened. The cup can help, but you really need to get a needle into several zones of the muscle belly. You don't need a trigger point. You don't need a motor point. You just need to get a needle to a muscle belly to release the muscle and elongate the muscle. So the cup is useful, but you're not going to rely on a cup. If you're going to rely on something that's not needling, rely on your hands. Manual therapy in that exact same direction of the needles is very useful for the quadratus lumborum, because you can just dig right into that really band of muscle belly and just coax it into releasing and relaxing, or at least try to. So the cup is, as you can imagine, the cup will help, but it's not going to be the best of the best, especially for deeper portions.
All right. And then Yvonne wants to know, how long do you leave these triad needles in?
Oh boy, that's a technique. That's a style question. I would say, generally speaking, if I'm treating the triad in the lateral recumbent position, I'm treating each of those 3 structures, as you saw in that one video. I would probably have those needed for 20 to 30 minutes with e-stim, so yeah. 20 to 30 minutes to me is reasonable for that. Yeah.
Okay. Leslie, do you do one side per treatment, or do you then flip them over and do the other side?
That's a good question. Generally speaking, if you go back to that Trendelenburg gait and you see that one of those gluteus mediuses is often weak, you want to treat one-sided, you know. If there is a trochanteric bursa or gluteal tendon tear, or if one side of the gluteus medius is contracted, one side of the quadratus lumborum is contracted, you want to treat one side and be very comfortable with one side treatment. There are cases where, say, you have a bilateral tightening and shortening of the quadratus lumborum, or you could have bilateral sacroiliac joint dysfunction, both palpate point sensitive. If that's the case, then maybe you need to treat both sides. You can put them lateral recumbent if that's the easiest way to get to them, and treat them for 15 to 20 minutes on the side, and then roll them over for another 15 to 20 minutes on the other side. I try as much as possible to treat one side if that's how the patient presents. I love asymmetric treatment. I don't like symmetrical treatments. I like asymmetric treatment. It creates much more of a kind of neurologic, you know, powerful, shifty thing. It's like treating opposite side and things like that. You're sending signals to the brain from one side and not both sides, and it sometimes the healing response is much more immediate and much more impressive with one-sided treatments. So, if possible, but if both sides are affected, you might have to do it, and you might have to both within a single treatment.
Okay, we still have a couple more questions, so hopefully you're still hanging in with us.
Fire away.
Actually, also might kind of go along with what you just said. So if you are treating somebody in the lateral recumbent position, do you try to treat both sides in the same treatment or in subsequent treatments? If the latter, how do you choose which side to start with?
I think I answered it already.
Okay.
The patient will usually come with one-sided back and hip pain. They have trochanteric bursitis, or they've got, they got right-sided lumbosacral pain. That's put them on their left side, right side up, and treat them one-sided. Even if the pain referral patterns go centrally, and I mean, I'm going to make a mess here, but I'm going to make a mess here. Even if the combined referral patterns, say, from the gluteus, medius, and minimus give you, look at this one in the middle where the red dots are right in the middle, right on top of the sacrum. Sometimes a case like that, when you palpate the gluteus medius, it's both sides, and sometimes you just have to treat both sides. But most of these other cases are one-sided dysfunction, and you can do it one-sided. So, yeah.
Okay, next question I can answer. Angel wants to know if we can watch this webinar again. Everyone will receive an email 5 minutes after we end that will have a recording, a link to the slides, and then also some great information for your upcoming classes and a discount from us. Our very last question, which we will have you answer if you're cool with, is, where did it go? Do you have cautions for partial and total hip replacement patients?
I stay away from replacement patients. I can't be absolutely definitive that I'm not introducing perhaps bacteria with a needle onto titanium, or I just can't be sure. So I'm going to just avoid the question, saying hip and knee replacement make me nervous. And I don't want to find out, certainly I don't want to do any low needling before all the risk of infection from the surgery have passed, so that they end up getting a post-surgical infection. I've got a needle in there. Now, it didn't cause the infection, but you know what? It was there, and it doesn't look good, So I just stay away from anything acute or recent on any of the replacement surgeries. And then I go very carefully. I don't have the experience to answer the question. I'm sure there's practitioners who can answer this question better. I have stayed with active and athletic patients and not with I just haven't treated enough replacement, hip and joint replacement to be knowledgeable and intelligent. So I'll pass that.
All right. Well, that was our last question of the evening. We can't thank you enough. I mean, this is your third webinar with us. Everybody enjoyed it. We are really grateful to you. So if you would, thank you to everyone who came tonight. I would like to announce that our next webinar is going to be a unique one. It's on February 6th. It's actually going to be a panel-style webinar on neuroscience acupuncture. It'll be featuring Amy Wolf, Michael Corradino, Clayton Shu, and Pony Chang. We have registration up on our blog already, so you can check that out there. It'll also be in the email that you'll receive after this. We just really thank you all for coming tonight. Check your inbox, check out WHIP's website, and have a wonderful evening.
See you all. Thanks for showing up. I see a lot of names on here of people I've never seen before, so never seen the names before. So that's cool. I appreciate that you listened to me. So thank you all, and thank you, Jeffrey. Thanks, Lhasa OMS. Appreciate it.
Well, thank you, Whit. Have a good night, everybody.
Okay. Bye-bye.
Take care.